Welcome to the Radong Smart Review CNS series. Today we're diving deep into a topic that truly showcases the incredible precision and versatility of our field. We're actually moving beyond the traditional focus on malignant disease.
Exactly. Yeah, we're exploring an application within radiation oncology that, leverages our unique capabilities to alleviate one of medicine's most severe, debilitating pain conditions, trigeminal neuralgia. It's a fascinating area where our expertise in targeting and dose delivery makes a profound difference in a patient's quality of life. It really does.
That's right. So for those of you expecting a discussion purely on tumor management, this is a compelling detour. We're focusing on the use of radiation to treat a functional neurological disorder, not a tumor at all. Our goal today is really to break down the clinical decisions that matter most for this highly specialized area, giving you a comprehensive understanding for your practice.
Yeah, this session is designed as a detailed guide specifically for you, our residents. We'll cover everything from the essential workup and the full treatment algorithm to a comprehensive workshop on the technique, dose, and outcomes of stereotactic radiosurgery for trigeminal neuralgia. Think of it as your shortcut to becoming well-informed on this topic.
Our mission is to equip you with, surprising facts maybe and practical insights that you can apply directly. By the end of this session, you'll not only understand the what, but also the critical why and how of managing this challenging condition with radiosurgery.
Foundations Understanding Trigeminal Neuralgia.
Okay, let's set the stage of the patient who embodies precisely why this discussion is so important. Imagine you're seeing a 78-year-old woman in clinic. She presents with a 5-year history of excruciating, debilitating right-sided facial pain. It's predominantly in the V2 and V3 distribution, so that's her maxillary and mandibular nerve areas. And this isn't just, a toothache or a headache. She describes her pain as sudden, intense, electric shock-like and lancinating. Each episode lasts only seconds, but is triggered by incredibly simple, everyday acts: chewing, talking, even a light touch to her face. Think about how disruptive that would be to daily life. Just awful. Now, her medical journey is crucial here. She's already failed maximal doses of first-line medications like carbamazepine and gabapentin. She experienced both incomplete pain relief and significant side effects from the drugs, so not great options for her there. To complicate matters, she has significant cardiac comorbidities. And it's actually led her neurosurgeon to deem her a poor candidate for open microvascular decompression, a major intracranial surgical procedure. So this complex clinical picture leads her directly to us. She's been referred for consideration of radiosurgery. Keep this patient in mind, because she's the quintessential candidate for the very treatment we're about to unpack.
Her case really highlights a perfect storm of factors that direct us towards stereotactic radiosurgery. And it aligns perfectly with the epidemiology of trigeminal neuralgia. What's kind of fascinating here is that while the overall incidence is relatively low, about 4 per 100,000 people, it disproportionately affects older adults and notably women. Our patient fits this demographic profile precisely, which just underscores the typical presentation we often encounter in clinic.
Okay, now that we've framed our patient and seen how common this is in her demographic, the next logical question for us, and probably for her too, is what's actually causing this excruciating pain? Let's really unpack the why behind the what. From what I understand, the vast majority of cases point to a very specific anatomical culprit, right? What's going on at the microscopic level?
You're absolutely right. The classic etiology, accounting for a significant majority, we're talking 80 to 90% of cases, involves a very specific anatomical interaction: vascular compression of the trigeminal nerve at its root entry zone, or REZ. This REZ is a critical juncture, precisely where the trigeminal nerve exits the pons, a vital part of the brainstem, and transitions from central myelin to peripheral myelin. Imagine the delicate myelin sheath, the nerve's protective insulation being constantly rubbed and compressed by a pulsating blood vessel, most commonly a branch of the superior cerebellar artery. Over years, this chronic friction literally erodes that myelin, similar to insulation wearing off an electrical wire, exposing the bare nerve axon. This naked nerve becomes exquisitely hypersensitive and prone to abnormal electrical activity. It's thought to lead to apoptic transmission, where electrical signals jump between adjacent nerve fibers, causing a light touch or a chewing motion, which would normally only generate a tactile sensation, to sort of short-circuit into an agonizing amplified pain signal. It's a structural problem, leading to a profound functional neurological symptom. It makes sense when you picture it like that.
And this distinction between types of trigeminal neuralgia This is a keyboard topic for a reason, isn't it? Because an accurate clinical diagnosis profoundly guides our treatment approach. We primarily differentiate between two types, and understanding these distinctions is absolutely crucial for proper patient selection, especially for radiosurgery.
Yeah, exactly. What's fascinating here is the precise definition of classic trigeminal neuralgia, or TN type 1, which describes our patient perfectly. It's characterized by a paroxysmal, lancinating, electric shock-like pain that lasts for seconds to minutes. It is strictly unilateral, meaning it affects only one side of the face, and it's confined to one or more trigeminal nerve distributions V1, V2, or V3, corresponding to the ophthalmic, maxillary, or mandibular branches. Crucially, it has clear trigger points. These can be as simple as touching a certain part of the face, talking, or, as in our patient's case, chewing. This diagnostic clarity and the presence of these classic features are what guides us to the appropriate, highly specific interventions.
Okay, so that's type 1. In contrast to that sharp, sudden pain, atypical trigeminal neuralgia, or TN type 2, presents quite differently. Instead of those explosive transient shocks, it's characterized by more constant, dull, aching, or burning pain. Often, it lacks those distinct, sudden triggers that are so characteristic of type 1. While still debilitating, this distinction is incredibly crucial for patient selection rate, because stereotactic radiosurgery is primarily indicated and most effective for the classic paroxysmal type 1 presentation. Attempting SRS for type 2 is generally less effective and, well, not really recommended, making this a critical differentiator in our clinic. So, if we're following a patient through their journey of managing this severe pain, where does the treatment algorithm truly begin? Before we even think about invasive procedures like SRS, the mainstay for first-line medical therapy involves specific anticonvulsants.
Exactly. Carbamazepine is the classic first-line agent, and it's remarkably effective for many patients initially, often providing excellent relief. It works by stabilizing the inactivated state of voltage-gated sodium channels, essentially dampening the abnormal nerve firing we just described. However, it's not without its drawbacks. Patients can experience significant side effects like dizziness, fatigue, nausea, rash, or, more seriously, hyponatremia or hematologic abnormalities. Other anticonvulsants like oxcarbazepine, gabapentin, lamotrigine, and baclofen are also used, either alone or in combination. But it's really important to stress that stereotactic radiosurgery, or SRS, is only considered after medical failure or intolerance to these medications. It's a stepwise approach, reserving more invasive options for when conservative measures are no longer sufficient or tolerable.
Right. So for those medically refractory patients, those who simply can't get adequate relief or tolerate the side effects of medications, there are several invasive options to consider before we even think about SRS. These are typically divided into open surgical approaches and percutaneous destructive procedures.
Indeed. The gold standard for younger, healthy, fit patients with classic trigeminal neuralgia is microvascular decompression, or MVD. This is an open neurosurgical procedure, typically performed via a retrosigmoid craniotomy. The surgeon identifies the compressing blood vessel, often the superior cerebellar artery, and gently separates it from the trigeminal nerve, inserting a small piece of Teflon felt between them to prevent future contact. It offers the highest rate of long-term pain relief, often providing immediate and durable results. However, it is, of course, the most invasive option, involving an open brain surgery with associated risks like CSF leak, infection, hearing loss, facial weakness, or even stroke. This is precisely why our 78-year-old patient with significant cardiac comorbidities would be deemed a poor candidate. The risk is just too high.
Okay, so MVD is the gold standard but invasive. And beyond MVD, there are other less invasive but still destructive procedures, often lumped under percutaneous rhizotomy procedures that target the Gasserian ganglion.
Precisely. These are typically performed by neurosurgeons or interventional pain specialists, often through a needle inserted through the cheek into the foramen ovale to access the Gasserian ganglion. They include techniques like radiofrequency ablation, where heat is used to create a controlled lesion on the nerve, glycerol injection, which chemically damages the nerve fibers, and balloon compression, which uses mechanical pressure to create microvascular damage and demyelination. These procedures offer immediate pain relief, which could be very appealing to patients suffering from acute severe pain. However, a significant trade-off is that they come with higher rates of sensory deficits, including more pronounced or bothersome facial numbness, dysesthesias, and sometimes even masseter weakness compared to SRS. While effective for pain, the quality of sensation after these procedures can sometimes be quite altered. It's a different kind of trade-off.
So given all these options, from medications to open surgery to percutaneous disruptive procedures, where does SRS fit into this complex picture? What's its unique strategic role?
Yeah, if we consider the broader clinical landscape, SRS is justified as a highly valuable, minimally invasive option for a specific subset of patients who present with medically refractory pain. It's ideal for those who are either poor surgical candidates for MVD, like our 78-year-old patient with significant cardiac comorbidities, for whom the risks of open brain surgery are simply too high, or for patients who simply wish to avoid a more invasive open procedure due to personal preference, occupation, or other factors. Her case isn't just an example. It defines the very niche where SRS truly shines, providing an effective, minimally invasive alternative when the gold standard is too risky. It's a bridge for patients who have exhausted medical options but cannot or will not undergo a major operation.
The SRS workshop technique, dose, and outcomes.
All right, now that we understand why SRS is considered, let's dive into the nuts and bolts of how we actually do it. For me, this is where the precision of radiation oncology truly shines, pinpointing that exact spot in the brain to deliver our therapy. Where do we begin when we're defining our target?
Without a doubt, the bullseye for our radiation is the root entry zone, or REZ. Specifically, we're targeting the cisternal segment of the trigeminal nerve. This is the portion of the nerve that's bathed in cerebrospinal fluid, located just a few millimeters from where it actually enters the pons. It's a critical area extending about 2 to 4 millimeters from the brainstem itself. That's our spot.
And what's the rationale for such precise targeting of the REZ? Why not a different part of the nerve, say closer to the Gasserian ganglion or further away? What's special about the REZ?
The rationale for this precise targeting is directly linked to the pathophysiology we discussed earlier. This REZ is the presumed site of that focal demyelination resulting from vascular compression. It's the junctional zone, where the central myelin from oligodendrocytes transitions to peripheral myelin from Schwann cells, making it particularly vulnerable to mechanical stress. By targeting this specific segment, we're aiming our radiation precisely at the area where the aberrant firing and pain generation are thought to originate, essentially attempting to disrupt those painful short circuits at their source.
Okay, so we've identified the target, the REZ.
Yeah.
Now, how do we actually deliver the radiation with such incredible accuracy? What's the standard technique involved in SRS for trigeminal neuralgia?
The standard technique involves using a single, incredibly precise 4-millimeter isocenter. That's essentially the focal point where all the radiation beams converge to deliver the highest dose. This small 4-millimeter sphere of intense radiation is meticulously placed directly onto the trigeminal nerve at the REZ. The goal is to deliver a highly conformal dose to this tiny target while meticulously sparing surrounding critical structures, especially the brainstem.
Precision is everything here.
And how do we achieve such exquisite visualization of the nerve to ensure that 4-millimeter isocenter is placed exactly where it needs to be, especially when we're talking about a structure so small and so close to the brainstem? High-resolution MRI sequences are absolutely crucial here. There are eyes in the skull, essentially. We're talking about specialized sequences like FIESTA or CISS. You might hear those acronyms. What makes these so critical is their ability to create an incredibly stark contrast between cerebrospinal fluid, which appears bright, and the nerve itself, which remains dark. This bright fluid dark nerve effect, often achieved with very thin, like Bayo 0.5 to 1 millimeter slice thickness, allows for exquisite visualization of the trigeminal nerve and, crucially, any tiny vessels pressing against it. These high-resolution MRI images are then carefully fused to the planning CT, or maybe a different MRI, to create a comprehensive three-dimensional roadmap for treatment, allowing us to delineate the nerve with sub-millimeter accuracy.
Okay, so we've got the target, the tool, the imaging. And how is the dose actually prescribed in this context? Are we aiming for a specific boundary or a central point?
The radiation dose is prescribed directly to the isocenter. In SRS, this typically corresponds to the 100% isodose line. That means the point where the highest dose is delivered is exactly where we've placed our target. This ensures the peak dose is centered precisely on the REZ, where we want to achieve the therapeutic effect.
Okay, so we're talking about a single, highly focused dose. What does the data tell us about the optimal dose range for SRS, for trigeminal neuralgia? Are there different dose strategies, and what's the evidence behind them?
Well, the standard range for SRS for trigeminal neuralgia is 70 to 90 gray, delivered in a single fraction. That single fraction high-dose approach is the hallmark of radiosurgery. And this is where the conversation gets really interesting, because what's become incredibly clear in the literature is a robust dose-response relationship.
A dose-response relationship. Okay. Tell us more about that. Are there any landmark studies that illustrate this point clearly, helping us understand the nuances of dose selection?
Absolutely. The landmark series from the Cleveland Clinic by Kotecha and colleagues, published back in 2016, provides compelling and widely referenced evidence. This was a very large retrospective study, including over 800 patients, which gives its findings significant weight and clinical relevance. The Kotecha study didn't just confirm a dose response, it quantified a critical dilemma. We learned that pushing to 90 gray offers a statistically significant 13% better 4-year pain control compared to doses under 82 gray. Specifically, they found a 4-year pain response of 92% for the 90 gray group versus 79% for patients who received less than 82 gray. This is a substantial and clinically meaningful difference in long-term efficacy, giving us tangible data for patient counseling. Really important stuff.
So 90 gray gives better pain control. We're seeing improved efficacy with a higher dose. But this improved efficacy, as with many powerful treatments, often comes at a cost, right? There's usually a trade-off we have to consider and discuss with our patients.
Precisely. You hit the nail on the head. The higher dose, while offering superior pain relief, was indeed associated with a statistically significant higher rate of facial numbness, or hypoesthesia. This finding highlights a critical clinical trade-off that we must discuss with every patient: the delicate balance between achieving maximal pain relief and the potential for a bothersome side effect like numbness. The core insight here isn't just higher dose is better relief, but how much more numbness are we willing to trade for that gain? This study gives us the data to have that precise conversation with patients, moving from some relief to this much more relief for this much more numbness. It's not a simple choice. It requires careful consideration of the patient's individual pain, their quality of life, and their tolerance for potential side effects, especially if their livelihood or hobbies depend on intact facial sensation.
Okay, that makes sense. So when we counsel patients who are considering SRS for their trigeminal neuralgia, what kind of initial success rates can they realistically expect for immediate and short-term pain relief? What are the metrics we use to quantify this?
Yeah, the initial success rate for pain relief, and we usually define this as achieving a Barrow Neurological Institute, or BNI, score of 1 to 3, is achieved in about 90% of patients. And just to remind everyone, the BNI scale is widely accepted. BNI 1 is complete pain relief without medication. BNI 2 is occasional pain not requiring meds. BNI 3 is some pain controlled with non-narcotic medications. So 90% achieving this level of freedom from debilitating pain is a truly strong initial response. It offers significant hope to those suffering from what is often described as, well, the most agonizing pain known to medicine.
90% is great initially. However, it's important to understand that, like many treatments for chronic pain conditions, the pain can recur over time. This isn't always a permanent fix for everyone. What about the long-term durability of this treatment? What should we tell patients about recurrence rates?
You're absolutely right. It's crucial to set realistic expectations for long-term durability. While initial success is high, complete off-medication pain relief, looking at 5 to 10 years, post-treatment is closer to 50 to 60%. This means that while a substantial number of patients continue to enjoy excellent, durable relief, a significant proportion, around 40 to 50%, may experience some degree of recurrence over time, requiring either a return to medications or consideration of further interventions. This underscores the chronic nature of the condition and the need for ongoing management.
Right, and a really important point for patient counseling, one that differentiates SRS from, say, the immediate surgical relief offered by MVD, is the latency, the time until relief actually kicks in. This can be a significant source of anxiety for patients, I imagine.
Absolutely. This is a critical and sometimes challenging counseling point. Imagine a patient who's been in excruciating pain for years, and they're finally getting treatment. Their natural hope is for instant relief. I remember one patient convinced that because the procedure was done, her pain should be gone the next day. We had to gently but firmly reiterate that the magic of SRS isn't a light switch, it's more like a slow-release medication. The median time to pain relief is approximately 1 month, sometimes even longer for maximal effect. This latency is thought to be due to the gradual biological changes induced by the radiation, things like progressive demyelination, axonal injury, or glial cell changes that ultimately calm the overactive nerve. So, our clear directive to patients is do not discontinue your current pain medications immediately. Stopping too early almost guarantees significant discomfort and, frankly, undermines their faith in the treatment. It's about managing that waiting period, which can feel like an eternity to someone in pain. Really, really important counseling point.
Definitely. So let's talk about the potential downsides. What's the most common side effect we need to discuss thoroughly with our patients when considering SRS for trigeminal neuralgia, and what does it typically feel like?
Facial numbness or hypoesthesia is indeed the most common side effect. The risk of developing some degree of numbness is dose-dependent, as we saw with the Kotecha study. Generally, it approximates 10 to 20% for any form of hypoesthesia. This can manifest as a tingling sensation, a dullness, or a decreased ability to feel light touch. Of that, about 2 to 5% of patients might find the numbness bothersome or inconvenient, perhaps interfering slightly with eating or speaking, though it's rarely functionally debilitating. Interestingly, it often correlates with a better pain response. It's almost as if the treatment is working by partially dampening the nerve sensation, and that dampening sometimes includes a sensory component. We grade this using the CTCAE criteria, so we have a common language to assess its severity.
Okay, 10 to 20% risk of some numbness, mostly mild. Are there any more devastating, albeit rare, complications that we absolutely need to be aware of and counsel patients about, even if the risk is very low?
Yes, unfortunately. Anesthesia dolorosa is a rare but truly devastating complication. This is described as a painful numbness, a paradoxical and extremely difficult to treat sensation where the patient feels numb but simultaneously experiences excruciating, burning, or aching pain in that numb area. It's a profound impairment of quality of life. The risk is very low, thankfully, around 1%, maybe less. But its severity necessitates mentioning during comprehensive patient counseling, as it's a side effect that can be worse than the original pain. It's rare, but we have to mention it.
Wow, yeah, definitely need to mention that. What if a patient initially responds well to SRS, but then months or years later experiences a recurrence of their pain? Is reirradiation an option, or is it a one-time shot with no second chances?
Reirradiation is definitely an option, which is good news for patients who do experience recurrence. For those who had a good initial response but later recur, reirradiation with a slightly lower dose, for example, 70 to 75 gray, to a slightly shifted isocenter is considered a reasonable option. The reasons for the slightly lower dose and shifted isocenter are multifaceted. A desire to reduce cumulative dose to the brainstem, account for potential small nerve movements, and manage the increased risk of toxicity with a second treatment. However, it's important to note that a second SRS comes with slightly lower success rates for pain relief and a slightly higher risk of numbness compared to the initial treatment. This nuance is important when discussing expectations with patients considering a second round of radiosurgery, as the outcomes, while still beneficial, may not be as robust as the first time.
Clinical decision-making and board review.
Okay, let's bring it all back. So, what does this all mean for our 78-year-old patient we introduced at the beginning? She presents with classic medically refractory TN type 1, and crucially, she is a poor surgical candidate due to her significant cardiac comorbidities. How does all the information we've just discussed apply to her specific case, and how would we present this to her?
Yeah, considering the broader clinical landscape, she's a perfect candidate for SRS. All boxes are checked. Classic type 1 pain, failed multiple lines of medical therapy, and a clear contraindication to the most invasive surgical option, MVD. The recommendation we would provide would be framed something like this, focusing on her individual situation. Given that your severe facial pain has not responded to multiple medications and your heart condition makes you unsuitable for open brain surgery, stereotactic radiosurgery is an excellent, minimally invasive option for you. Quote, we would deliver a single, highly focused dose of radiation, typically 80 to 85 gray, to the trigeminal nerve precisely where it exits your brainstem. We emphasize minimally invasive and highly focused to highlight the benefits given her comorbidities.
That makes sense. And how would we counsel her on the expected outcomes, managing her expectations for both relief and potential side effects, ensuring she has a clear, comprehensive picture before consenting?
Right. For counseling on outcomes, the conversation would be comprehensive and clear. This treatment has a very high success rate, with about 90% of patients experiencing significant pain relief. It's important to know that the relief is not immediate. It usually takes about a month to start working, so you will need to continue your current pain medication during that time.
So
The main side effect we discuss is a roughly 10 to 20% chance of developing some mild numbness on that side of your face, which many patients do not find bothersome and can even be a sign that treatment is working. The risk of more serious complications like painful numbness is very low, less than 1%. This covers the key points on efficacy, latency, and toxicity in a balanced, patient-friendly manner, empowering her to make an informed decision.
Perfect. All right, let's shift gears slightly to some clinical pearls. These are concise, high-yield takeaways for your exams and for your practice, distilling the most critical information we've covered into memorable bullet points.
Okay, pearl number 1, focusing on targeting. The root entry zone, or REZ, specifically the cisternal segment of the trigeminal nerve, is the unequivocal standard target. You should aim to position that 4 mm shot about 2 to 4 millimeters from the pons. Precision here is paramount, and it's the anatomical sweet spot for efficacy.
Pearl number 2, regarding safety. This is crucial. For brainstem safety, which is paramount when delivering a high dose so close to vital structures, two absolute non-negotiables are keeping the maximum dose to the pons, that's our Dmax, to less than or equal to 12 gray. And, crucially, avoiding any contact between the 50% isodose line and the brainstem itself. Think of that 50% isodose line as a protective halo around our high-dose region. If that halo even touches the brainstem, we're putting critical neurological function at unacceptable risk. Can't stress that enough.
Absolutely. Pearl number 3, on dose strategy. The initial dose for SRS, for trigeminal neuralgia, is typically 80 to 85 gray, prescribed to the 100% isodose line. Remember, the Kotecha study's critical insight. 90 gray offers more pain relief, but also carries a higher risk of numbness. This is a crucial shared decision-making point. If re-SRS is needed down the line, the dose for the second treatment is generally 70 to 75 gray, often with a slightly shifted isocenter to manage cumulative dose.
Got it. Pearl number 4, regarding best responders and durability. The best responders to SRS are typically patients with classic TN type 1 and those who do not have multiple sclerosis. That's an important distinction. The latency to pain relief, as we emphasized, is about 1 month. In terms of long-term durability, a BNI score of 1 to 3, indicating a good to excellent response, is durable in about 50 to 60% of patients at 5 to 10 years. This helps set realistic long-term expectations.
And finally, pearl number 5, a summary of side effects. Expect about 10 to 20% of patients to experience some degree of facial numbness. Of those, bothersome numbness occurs in about 2 to 5%. And remember, the devastating complication of anesthesia dolorosa is very rare, thankfully, occurring in less than 1% of cases. But it's a risk that must be mentioned.
Okay, we've distilled the core knowledge into our pearls. But how does this translate under pressure? Let's put those pearls to the test. Imagine yourself on your oral boards or preparing for a written exam. We're going to hit you with a quick board blitz, a few rapid-fire cases designed to reinforce these concepts just as you see them on an exam. Ready?
Let's do it.
Question 1. A patient with classic trigeminal neuralgia is being considered for SRS. What is the most common anatomical target for this procedure? Is it A, the Gasserian ganglion, B, the trigeminal nerve root entry zone, or REZC, the trigeminal nucleus in the brainstem, or D, the superior cerebellar artery?
Okay, the best answer is unequivocally B, the trigeminal nerve root entry zone, or REZ. The clinical reasoning is rooted in the underlying pathophysiology of classic trigeminal neuralgia, which, as we discussed, is thought to be vascular compression, causing focal demyelination at the REZ, where the nerve exits the pons. This makes the REZ the precise anatomical target for stereotactic radiosurgery, as we are aiming to disrupt those abnormal pain signals at their point of origin. Targeting the Gasserian ganglion A is for percutaneous destructive procedures, while the trigeminal nucleus C is the central processing area, and the superior cerebellar artery, D, is often the cause of the compression, not the target of radiation. So definitely B.
Excellent reasoning. Question 2. A 75-year-old patient is counseled about SRS for medically refractory trigeminal neuralgia. Which of the following is the most accurate statement regarding the expected timeline and side effects? Is it A, pain relief is immediate with a 50% risk of severe numbness? B, pain relief takes about 1 month with a 10 to 20% risk of mild numbness? C, pain relief is immediate with less than 1% risk of any numbness? Or D, pain relief takes about 6 months with about a 30% risk of mild numbness? The best answer here is B. Pain relief takes about 1 month with a 10 to 20% risk of mild numbness. The clinical reasoning is that a key counseling point for SRS, for trigeminal neuralgia, is the latency to effect, which, as we emphasize, is typically around 1 month due to the gradual biological changes induced by radiation. This means immediate pain relief, A and C, is incorrect. Furthermore, the most common side effect is mild facial numbness or hypoesthesia, which occurs in approximately 10 to 20% of patients with modern dosing, making the 50% risk of severe numbness, A, and 30% risk of mild numbness, D, inaccurate, and less than 1%, C, far too optimistic. So B fits the data best.
Agreed. B is the correct answer based on latency and toxicity rates.
All right, final one, question 3. According to the large series from Kotecha, what is the primary trade-off when selecting a higher dose, for example, 90 gray, versus a lower dose, for example, less than 82 grays, for trigeminal neuralgia, SRS? Is it A, higher dose improves local control but worsens survival? B, higher dose provides better pain relief but increases the risk of facial numbness? C, higher dose provides faster pain relief but has a higher recurrence rate? Or D, higher dose has a lower risk of numbness but worse pain control?
Okay, the best answer here is B. Higher dose provides better pain relief, but increases the risk of facial numbness. The clinical reasoning is that the Kotecha study, a cornerstone in this field, clearly demonstrated a dose-response relationship for pain control, with 90 gray providing superior, durable pain relief compared to lower doses. However, this increased efficacy came at the cost of a statistically significant increase in the rate of treatment-related facial numbness. This precisely highlights the critical trade-off that we weigh during treatment planning and patient counseling, emphasizing the shared decision-making process. The other options are either incorrect or not supported by the Kotecha data. B captures that core finding.
Perfect. Word blitz complete.
Broader context and final thoughts.
Now, to help you remember the key features of classic trigeminal neuralgia type 1, let's use a mnemonic that captures all those essential diagnostic points. Think of a TRIGGER. The T stands for type 1, which is the classic form. The R is for root entry zone involvement, that vascular compression. The I represents intermittent, intense electric shock pain, that quality. The first G refers to the pain being generally gone in seconds to minutes, paroxysmal. The second G signifies that the pain is generated by specific gestures like chewing, talking, touch those triggers. The E stands for exclusively unilateral, one side only. And finally, the R is for response to carbamazepine, the classic first-line drug, TRIGGER. Hopefully that helps lock it in.
That mnemonic is truly clever and effective. It's exactly the kind of structured recall residents need when facing these cases in the clinic or on an exam. It perfectly consolidates all those critical diagnostic points into a memorable framework. Nice one. Now, stepping back to consider the broader clinical landscape, let's revisit our worn electrical wire analogy for the trigeminal nerve's demyelination. Imagine that frayed insulation causing painful, unpredictable short circuits. Now, surgery, specifically microvascular decompression, or MVD in this analogy, is like physically moving the offending object, the blood vessel, to immediately fix the wire, restoring its proper function right away. That's why patients often report instant relief from MVD.
Right, the immediate fix. So how does SRS fit into that analogy? How does our radiation treatment compare to that immediate surgical fix, especially with that crucial latency period we keep talking about?
Yeah, SRS in this analogy is like applying a highly precise, invisible, slow-acting sealant to that frayed insulation. It doesn't instantly repair the wire. You don't get immediate pain relief. Instead, it initiates a gradual biological process over weeks, causing maybe scar tissue or a slow, localized demyelination, or perhaps even a neuromodulatory effect that calms the nerve over time. This targeted energy deposition leads to a progressive fibrotic reaction around the nerve, which can reduce its hypersensitivity, or even lead to a localized controlled denervation, effectively silencing the aberrant pain signals. This explains why the pain relief isn't immediate, but rather takes about a month to seal the leaks and restore smoother function, reducing those painful short circuits. It's a testament to the sophisticated radiobiology at play.
That's a great analogy. Now, the Kotecha study, which we discussed in detail, highlighted a critical discussion point: the trade-off between using a higher dose for potentially better long-term pain control and the increased risk of facial numbness. This isn't a simple black and white choice, is it? It requires a thoughtful conversation with each patient.
It really isn't simple. This raises an important question. How do you actually have that conversation and navigate that decision for each patient? It profoundly emphasizes the importance of shared decision-making. As clinicians, we need to carefully weigh a patient's pain severity. Is it absolutely crippling, impacting every aspect of their life, their overall quality of life, their tolerance for potential side effects, and their overall goals for treatment? For some, even a small increase in numbness is unacceptable if they are a musician or a speaker or depend heavily on fine facial sensation. But for others, maximal pain relief at almost any reasonable cost might be the priority. We often use visual aids, showing them the numbers, the percentage likelihoods from studies like Gotecha. We also discuss what that numbness might feel like. Is it just a dullness, or could it interfere with eating or speaking? It's not just a numbers game. It's about understanding their deepest fears and hopes and truly tailoring the dose to their individual circumstances. It's truly not a one-size-fits-all approach. It's a personalized discussion every time.
That personalization is key. And the fact that we even have the option for reirradiation for recurrence also represents a significant advance, doesn't it? It offers a second chance for relief while, of course, managing expectations for slightly altered outcomes in terms of efficacy and side effects compared to the initial treatment. It's a powerful tool in our arsenal for chronic pain management.
It really is. And what's truly fascinating here is how radiation oncology continues to expand its reach. We're often seen primarily as cancer specialists, right? But this application, targeting a functional neurological disorder with millimeter precision, redefines our scope. It highlights how our understanding of radiobiology and targeting accuracy isn't limited to cell death and tumors, but extends to subtle neuromodulatory effects that can restore quality of life. The insight for residents is, don't pigeonhole our specialty. The future of radiation oncology includes being pioneers in functional neurosurgery and neurological disorders as much as oncology, offering sophisticated, minimally invasive solutions for conditions that severely impact quality of life. It showcases the incredible versatility and precision of our field. It's quite exciting, actually. Summary.
So let's wrap up. Today, we've completed our thorough exploration of stereotactic radiosurgery for trigeminal neuralgia. We started by understanding this debilitating condition through the lens of our 78-year-old patient, differentiating classic from atypical facial pain, and establishing the precise role of SRS in the broader treatment algorithm for medically refractory cases, particularly for those who are not surgical candidates.
We then dove deep into the SRS workshop, detailing the technique of targeting the root entry zone, or REZ, with a single 4mm isocenter, and prescribing a dose of 70 to 90 gray, informed by those critical dose-response relationships. Finally, we reviewed the expected outcomes, emphasizing the crucial 1-month latency to pain relief and the typical 10 to 20% risk of mild facial numbness, alongside the keyboard pearls and clinical decision-making points that are indispensable for your practice. Outro.
Thank you so much for joining us for this in-depth discussion on SRS for trigeminal neuralgia. We really hope this session has provided you with valuable insights and practical knowledge for your radiation oncology practice.
And to further solidify your understanding and prepare for your exams, remember you can complete practice oral boards at radoncsmartlearn.com. Don't forget to subscribe to Radon Smart Review for our next episode as we continue our CNS series. Thanks for tuning in.